being open means I can't blame the depressed heart function on that. Okay, so we took that out of the equation, and I'll show you what those look like. I feel that it's probably due to the AFib and the heart rate being so high. Measuring the pressures in there, he's still got a lot of volume on him. I'm going to put him on a medication. It's an IV medication to help make the heart work a little harder, to try to push blood forward. Sometimes that helps the kidneys get more blood flow. It can help those improve, and if the kidneys get more, then sometimes they can diurese better. So that medicine can drop the blood pressure a little, so we have to watch. I don't know how his response is going to be to it until we do it, but I think if we keep doing what we're doing, we're kind of spinning our wheels right now. You know? Bear with me. Let me get them to send it over. They haven't. Can you guys ask them to send those pictures over for me, please? So I think this weekend we lay low and just try this new medicine and see if it works. It's called milrinone. There's a couple of different ones we can use. Some of them work by making the heart just squeeze harder. Some of them work by making it squeeze faster. I don't think the one that makes it squeeze faster would be a good option because we could trigger the AFib again. That one's called dobutamine. So we'll stick with milrinone for now, and we'll see how he does with it, okay? And the way we're gonna know how he does is watching his kidney function and watching how much urine he puts out. So his I's and O's, the nurses call them, the ins versus the outs, is gonna be very important and kind of a way that we figure out how we're doing.
Will kidney function with torsemide or Lasix or whatever?
So they had him on torsemide. They held it today. They're actually giving him fluids today to help protect the kidneys, knowing we were going to give him some contrast today. And so the nephrologists are helping us with that. Oh, they sent.
She said just try to reboot it.
Reboot it? Okay.
Yep.
Oh, see, when he just went before the procedure, that was with Lasix or torsemide. They had already given him something.
And
Well, we planned this, right? I mean, it's not like we did this emergently. We said, let's get the kidney docs to.
I was thinking he went on his own. That's what.
Because he peed a lot right before the surgery.
Oh, gotcha.
So he had some fluids in preparation.
Yeah, exactly.
So that helped the kidneys to start. Yeah.
Okay, so here's this little balloon tip catheter. This is the one that I took up into the lungs. So here I'm going through the right atrium, through the right ventricle, and I'm out in the lungs here. And that's measuring the pressures. That's what allows me to see if there's too much fluid out there. Now this is the actual arteries on the heart muscle. These are the ones that he was born with. You know, he's got some blockages here. This is where they bypassed it, and I'll show you the bypass in just a moment. We take a picture of the native arteries first. This is the bypass to the right. You see how nice that is? So it looks good. This is another picture of it. Here's the native right that they bypassed. You can see it's blocked down here. There's an old stent down here. Now this is the bypass up in the chest wall, the artery that comes down and touches onto the left anterior descending. So the bypasses are all functioning. That's called the lima, or left internal mammary artery there. And this is the vein that they removed from his leg and attach that down to the posterior descending artery off of the right coronary artery. So both the bypasses are open, and that's what, Dr. Cath is absolutely correct. We want to make sure that those didn't have a problem and that affect the heart muscle. So I think the key here is let's get the fluid off, because that right heart cath, the one I showed you where we measured the pressures, it did support that there was still too much fluid. So we're going to work on that.
So by the removal of the fluid, that could strengthen his heart in and of itself.
Yeah, so what it could do, a couple things. Number one, now that he's out of the, think about if you work out and your muscle gets tired and fatigued, after it recovers, it comes back, right? So kind of similar thing, maybe we make sure his heart rate's controlled, which it is now, he's in a normal rhythm. That what's called tachycardia-induced cardiomyopathy from the fast heart rate that could be what, you know, really precipitated the decrease in the heart function.
Warm out. You just
Yeah,
warm out
exactly.
From just racing so
Mhm.
much. It's just, yeah.
Versus this regurgitation, this mitral regurgitation, because boy, that sure did progress very quickly. You know, because when he was in Johns Creek, it wasn't like that. So I think that could be also just a function of too much volume on him, and maybe that improves when we get volume off. But we do need to relook at that, and that's where that transesophageal echocardiogram that he discussed comes in. So we don't have all the answers. He is, I'll be honest, he's a sick guy, right? So I want to be very clear that that heart function is about 20%, normal being about 60%, 50 to 60. And when it's pumping like that, it's not delivering all the oxygen it needs to. And so we're not out of the woods by any means, okay? But I think we definitely need to try a different route,
Going
which I'm going to
forward.
try that medicine to see if it'll help get some fluid off and go from there.
Okay.
Heart can improve sometimes very little time, sometimes it can take months.
And he'll still the amiodarone?
Still in the amiodarone. Sometimes it doesn't improve, okay? We just don't know yet.
Yeah.
It's too early to tell, and no one has a crystal ball. Okay?
Yeah,
Okay.
I can-
Thank you so much.
All right, no problem. I think they brought it.
Thank
Did they bring you back yet? No?